Uncensored with questions and discussions. As far as discussing this, I thought a bunch and I've sent you guys a bunch. And so disseminating knowledge is important because unfortunately there is a lot that is still not known. We don't know all the science. We're trying to determine the science. However, we do know certain basic principles of respiratory illnesses as well as epidemiology. Moreover, what's interesting is that specifically the knowledge is disseminated rapidly, and so we have to creatively use our digital technology, just like now, to encourage communication amongst each other 24/7. And so that's once again why I'm making sure this gets recorded and will be put up on my YouTube channel that my 16-year-old son just created for me, so that if any of you want this to be seen by somebody else, I encourage you then to find the link and we'll make sure that we can publicize the link. This is not an official discussion. I'm not doing this as a government agent. I'm not doing this as a hospital agent. I'm doing this as a clinician, trying to provide clinical information to other clinicians because we know something's coming. COVID-19, referred to as a coronavirus, there's 50 coronaviridae, and most coronaviruses are benign. They are actually contributors to URI symptoms similar to rhinovirus. This coronavirus is different because it turns out that in a certain subset of population, it can lead to lower respiratory tract infection with a viral pneumonia, but more actually, probably better to call it a pneumonitis. When it occurs in a predictable fashion. The individual presents usually after 5 days of illness, typically with fever, but not always. The fever will occur at one point during the illness and usually continues. The fevers are typically high. When the patients present with respiratory complaints, there have been descriptions of them presenting with severe hypoxemia without complaints of dyspnea, so that they have oxygen saturation on room air of 40 to 50% without actually telling you that they're short of breath. This is part of the reason for the alarmism, because we're trying to figure out this disease and we get these reports. And this is obviously almost sounding like a flash pulmonary edema type presentation. When the data are being actually looked at from Italy and now the UK, it appears that these patients, when they present and they have respiratory failure, rapid intubation is essential so that further bad outcomes do not occur. Non-invasive ventilation has not been shown to be successful, and in addition, non-invasive ventilation does seem to be associated with a very high risk of acquisition of the virus in healthcare workers. When intubation is to be done, ideally it is done with the intubator wearing PPE. This may not be possible in certain situations, but anything that can be done to reduce your risk of acquisition of the virus, N95 mask, surgical face mask, etc.
3 minutes. Yeah, it's live.
As far as when you should decide to intubation, the British data that's already just coming out, and I tried to send to the group, from UK King's College, they found that when patients had a presentation CBC, if you do a ratio of the neutrophils to the lymphocytes, and if the ratio is greater than 3.5, they actually are recommending in the UK intubate immediately. And it does seem that this neutrophil lymphocyte ratio at this time is a quick and dirty way of providing clinicians a sort of additional confirmation of their overall clinical gestalt. You look at the patient, you're worried about the patient, they're hypoxemic, intubate. Once the patient is intubated, they typically need to be on the ventilator for 10 days. This is based on Italian descriptions as well as UK descriptions, and they are confirming the Chinese descriptions when the outbreak was first getting characterized. The 10 days is because when the patients are extubated early, they fail and then get re-intubated with the expected sequela and bad outcomes that could occur in that setting. As far as other issues, proning has also been shown to be very helpful. And I am not a critical care doctor. I am the doctor that helps the critical care doctors. You guys know this kind of stuff and compliance and respiratory mechanics much better than I do. But it is striking how much proning does help. Based on what we are seeing, this does not appear to be a disease that requires ECMO. So this is not influenza. It is different. And with good ventilator techniques, the ICU will be able to provide the supportive measures that are needed for these patients. When patients are intubated, then they also talk about the usual methods that we know with ICU care really over the last 20 years of sparing, ventilator sparing, permissive hypercapnia. These issues, which are already well established and well known, need to be widely rolled out. Other things that we know clinically about this syndrome at this time is that there are testing to confirm it. So questions have been posed to me as to others. Okay, what's going on with the testing? It's all over the media. Why can't we get testing? What is going on with testing? Well, when we test for a virus, viruses are not that easy to test for because a virus is not discovered with what we call direct methods. Direct methods is when you see it. So if you see it, you know it's there. There's Staph aureus, it's a gram stain, you see it. Viruses are picked up with what's called indirect methods unless you use polymerase chain reaction. Polymerase chain reaction is a direct way of measuring the virus using advanced biochemical methods. It is not a kit, as the media describes, although there are ways to mass produce virus testing. Viruses, when they are tested for in a mass-produced fashion, the test has to go through a ramp-up phase, has to be mass-produced, and then has to be validated, because clinicians cannot have false positives or false negatives. We need to have a good specificity and sensitivity. Realize that the best example right now for us is the flu test. We all get frustrated with the rapid flu test. We get frustrated with, oh, we have somebody that's flu A negative, but then we bronked them and then they're flu A positive. So testing is coming. As it stands today, March 17th, 2020, at Baylor University Medical Center, the way the testing has to be done is we have to go through a system of steps to basically get the test done. And this is not because anybody is against us or it's a conspiracy, but it's because we're trying to test the ones that are most likely to turn positive. And these tests are not as widely as available as we would like. So there is the command center. They've posted the number all over the hospital. If you need to have the test, you need to call the command center. You need to be polite. You need to say, all right, we're all in this together. We're trying to get the test. Yes, we would like it if we could test everybody. Yes, we would like it if we could test every single healthcare provider. We can't yet. And they're rolling out the test. They're still trying to figure out. We're going to get conflicting information on when the test is coming out. But that's okay. Because in the Italian experience, they actually are showing that many times they didn't really need the confirmatory test because they could see the patient came in, respiratory failure, fever, severe lymphopenia, and then they found this neutrophil to lymphocyte ratio. Other tests that can be done easily is you can get inflammatory markers, specifically a CRP and a ferritin, and those will both be elevated. Lastly, in over 95% of the ICU patients described so far in China and in the ICU, the procalcitonin is normal. So that's useful because that's a test, kind of like a D-dimer, that we've kind of looked at critically and said, you know what, this test isn't as useful as we thought it could be. But in this situation, this is a test that is widely available and clinicians can use it so that you can say, all right, if my procalcitonin is sky high, it means I probably have an alternative diagnosis to consider in my patient because I know getting a COVID-19 test will not be immediately obtainable. Another comment, what if the patient that you have with respiratory failure already has another explanation? So what if they actually are flu A positive, or if you get a respiratory panel and find a different respiratory pathogen? So example, metapneumovirus, RSV, parainfluenza, et cetera, the whole usual rogues gallery of respiratory illness. It seems that that's very helpful. Now, nobody's going to say, oh, yeah, there's no way that there's going to be a co-infection and that there's going to be two different infections going on at the same time. But based on the Italian data, it does appear that if you get that, that should provide reassurance. So if the patient is flu A positive, it's flu A. Are we going to start seeing exceptions to this? Possibly, but we haven't yet. It hasn't been described, but we're obviously going to be paying attention. Recognize also that a lot of the things I'm saying today on March 17th, 2020 may change in a week, may change in a month. And we're all trying to figure out the fluid change of this clinical scenario. So the patient comes in, the patient is suspected, or maybe the patient isn't suspected. What about the patient with ARDS, but they have other reasons? What about a patient who had surgical complications and 2 or 3 weeks after surgical complications, for established reasons, develops acute lung injury? Maybe because of trolley, maybe because of pancreatitis, maybe because of other well-established pathways within critical care medicine. Well, that's important for everyone to remember, because family members, patients, family members may actually be concerned and say, wait a minute, you guys are rounding on my loved one. They've been here for a month. You're telling me they have ARDS. I'm looking up ARDS on Google. Remember, every one of your patient's family members is looking everything up on Google. And rather than fighting it, just accept it. Just say, all right, you're looking up things on Google. Thank you. We're all using our technology. This patient has ARDS. I'm a clinician. Let me tell you why this patient has ARDS. It's not COVID-19. The family members may say, I demand a COVID-19 test. Well, unfortunately, right now, the reality is that's something that can't be done. We can't sit there and say universal testing for COVID-19. Of course, there are some public health reasons we would like to do that. Cannot be done. So you've got your patient. They're in the hospital for a different reason, because we're going to have non-respiratory illness patients in the hospital. Ideally, our system will be able to handle the surge and continue to take care of the usual chaos that we get in clinical medicine, whether it's the trauma services, the surgical services, etc. Moving forward, a lot of the hospitals are now trying to prepare for the surge that is expected to happen. The surge is very hard to predict. The surge is something that was seen in Italy and is now being seen in France, Germany, and United Kingdom, and we will likely see a surge as well. We are not sure what the surge means. We do not know how exponential the surge will be. Public health authorities are interacting with our governing bodies, and we are seeing on the media how they are closing things left and right to try and reduce transmission rates. Yes, that is very interesting from a public health standpoint. Yes, some of us are very interested in public health, but that's not what this lecture is about. This lecture is about, all right, we're here, we're in the hospital, how do we get ready and what do we do? So if we're thinking about the surge, and if we're worried about the surge, the creative thinking has to be my patients that aren't in need of these techniques. If I have patients that don't need to be intubated, if I have patients that don't need to be in the hospital, is there any way I can get this patient out of the hospital? You have to be more creative. You know, can I maybe use oral agents? Can I maybe transition to oral antihypertensives? Can I maybe use oral diuretics? Can I maybe send the patient home on Friday so the patient isn't here through Monday? I think that's really going to come down to an individual clinician's decision. We're going to have to force ourselves to discharge patients quicker so that we can handle the surge that's coming. Within committee meetings, they're talking about, well, we need to discontinue elective surgeries. We need to define what an elective surgery is. We need to define what an elective case is. I'm not part of those committees. And those committees, that's why we have them. And there's going to be lots of argument and there's going to be lots of discussion between others. Okay, I really need to do my case. Well, yes, you need to put in a pacemaker, but you can't do it this week because we got to be ready for the surge. So the surge is happening. We just don't know when. This is going to be like a hurricane. For those that have you grown up on the Gulf Coast or on the Atlantic seaboard and you knew you're getting ready for the hurricane, well, we get ready and then we know the hurricane's coming. We don't know exactly when the hurricane's going to hit, and we don't know where the hurricane's going to hit, but we know it's coming. And then sometimes we roll our eyes when the media is wrong and the hurricane that was supposed to be bad wasn't bad. But then when the hurricane comes and it is bad, and we were warned that it was bad, we sometimes get upset that we weren't warned enough. We didn't do enough. Us, on this call right now, every one of you is a leader. We cannot complain. We cannot sit there and roll our eyes. And we cannot sit and say, oh, you know, the hospital messed up, or the government messed up, or the city messed up, or the county messed up. No, because look at history. Look at New Orleans. Could they really have prepared for Hurricane Katrina? Could they really have prepared for the levees breaking? No. We're going to have to be sticking together, and we're going to have to do this properly. And to do it properly, we got to look at each other in the eye. We got to talk to each other nicely. If somebody's grumbling, whether it's a comrade, like your colleague, you're there in the ICU together. Maybe it's a nurse. Maybe it's a nurse's aide. We're all in this together, and I really think we need to kind of slow down and try and have a kind word within each other. So the surge comes. The patients are sick. We have these ventilators that are supposed to help them. Are there other things we can do? Are there other therapies that we can provide? Unfortunately, the science is woefully behind that very important question. There are antivirals that may provide benefit. In China, they were looking at the use of Tamiflu. It is pretty certain that Tamiflu doesn't provide any benefit. However, there are still some recommendations of using it. There are recommendations of maybe using Kaletra, which is an HIV medication that's been around for almost 20 years. This comes from initial observations with MERS. When MERS happened, they found that Kaletra was somewhat beneficial. As a virologist and as an infectious disease physician, I am very familiar with the fact that when I kill a virus, I need more than one antiviral because of the mutagenesis that my antiviral may precipitate. These are very good thoughts. We have no clinical data to support that for this coming tidal wave. So we're going to look at different antivirals. We're going to talk about it. But we can't just throw everything at once at a patient because we don't even know if we're hurting them. We don't know if the Kaletra is going to help. We don't know if other antivirals are going to help. We have to say, all right, we know the ventilators help. We know that the patients have to be in the ICU for a fair amount of time. We know that we have to figure out how to use our ventilators properly and how to help our hospital by emptying the hospital so we can be ready for the surge. If we want to do directed therapeutics, antibiotics might help. Some of these patients may get bacterial superinfections. We will have to be clinicians, and we will have to assess these patients on a routine basis. If we're going to use antivirals, we probably need to talk it over with our colleagues. We need to not make it as a single decision, but we need to discuss with specialists, whether you're infectious disease colleagues, pharmacy, other critical care, whether the critical care is going to be medicine or surgical, don't really know. They're still kind of working on that process. We probably will try some antivirals. They're looking at a clinical trial to be rolled out here at Baylor, both within Baylor University Medical Center and Baylor All Saints. And this will be a clinical trial where we're collaborating with Gilead. And it is with an antiviral called remdesivir. And this antiviral had been looked at previously for Ebola. And there are data that suggests that it works. So a clinical trial is needed. And so we hope to have this clinical trial up and running, maybe even later this week. So the bureaucracy actually has been moving swiftly. And so this is a good example of how everybody's coming together, recognizing how important this is. And we have to think scientifically. Everyone is going to look to us for leadership. They're all going to ask not just me questions, they're going to ask you questions too. What do you think? What's going on in the hospital? Well, when you're in the hospital, wash your hands. Every time you touch anything, wash your hands and tell everybody you're washing your hands. And when you wash your hands and do it however you need to so you can get 20 seconds of hand washing. Whether you want to sing the Star-Spangled Banner or your favorite limerick or whatever. I don't care, but whatever works for 20 seconds, and do it as much as you can. There is no downside to washing your hands. And encourage everybody to wash their hands. And yes, you can do the gel afterwards, but I'm kind of doing both now. So that's actually an interesting intervention that I wouldn't have actually really emphasized in any other illness, but that certainly will help us and our patients. Other interventions for patients are a little different. They think that when the patients develop refractory hypoxemia with respiratory failure, that it is in the setting of a cytokine storm. Cytokine storm is a useful expression to share with patient family members if you're talking about it. When I shared this with my 16-year-old, he said, "Dad, it sounds like a band." And so he went and looked it up on Google. And then when he looked it up on Google, he actually saw a lot of the stuff that I was talking about. Use those kinds of techniques so that you can validate yourself if you're talking to others who don't realize that actually we're probably the most experienced people around taking care of sick people. So even though we don't know everything about COVID-19 like we say do about HIV or how we're quite sophisticated with influenza, we will know more about COVID-19. We know about critical illness. We know what we need to do. Well, the IL-6 cytokine storm, or I said the cytokine storm has been found to probably be mediated by IL-6. And there are some suggestions that if you check IL-6 levels, that a high IL-6 level may be predictive of worse outcomes. The Chinese noted this, and they started looking at an IL-6 blocker, which is called Actemra. And Actemra has been used in this country for asthma. So it's a drug that's available, but not readily available and not in plentiful supply. So we shouldn't just be using it left and right because, oh, we think it might help. We actually don't know if it'll help. No randomized data have been shown. In fact, it may be harmful. We don't know. When you look at the history of our fight against viruses, I find what's instructive is the early 1990s with HIV. There were lots of discussions on antivirals that could be used to try and stop this unstoppable virus. There was a relative lack of antivirals in the early 1990s. There were actually papers in 1992 and 1993 where they actually tried to give interleukin, they tried to give cyclosporin, thinking that AIDS was a consequence of immune dysregulation as opposed to immunosuppression. Randomized controlled trials determined that these interventions were bad. Like, bad outcomes happened, the trials were stopped early, and so of course we don't give cyclosporin to patients with HIV to treat their HIV. And I think that's another way for us to think scientifically. Yes, I see on my feed, when I look at Reddit, I see there's this new medication, there's this, there's that. It's very frantic, but clinically, I know ventilator works, intubation works, ICU care works, proning works. I don't know if anything else works. I know that I got to monitor for complications from ventilators. We know how to do that. And I know that I got to get the hospital emptied so that I can accommodate the surge. So the trials that will probably start coming will hopefully help us answer this. We don't know what's in store for us. We don't know what the outcomes of the trials are going to be. When we know more about the trial and when the trial will be enrolling patients, basically we're looking at two different trials. There's a moderately ill trial and a severely ill trial, and basically the breakdown is oxygen saturation of 94%. If the patient has hypoxemia with oxygen saturation of less than 94%, they are considered to be severely ill, but they can't be intubated yet to be enrolled in the trial. If they are considered moderately ill, then moderately ill would be less than or greater than 94% saturation on oxygen. Lastly, oh yeah, additional diagnostics. So there's been a lot of interest on CT scans. And apparently there are some changes on CT imaging that may be helpful in diagnostics. This may be an adjunct to virologic testing, which we recognize is unfortunately not widely available. Yes, CT imaging does provide help. However, transporting a patient from the 4th floor to the CT scanner and then all of the potential exposures that this could precipitate probably can't be done. You know, a lot of us, when we went through our training, we were always kind of forced to get an A because that's what we were always told. You got to get this so you can get an A, so you got to get your straight A so you can get to the next step, and then you get to the next step. Please don't try to get an A on all these patients. Please try and recognize, all right, I have my data. I may not be able to get the CT scan I want. I may not be able to get the virologic testing as fast as I want. However, we may get it. What if the patient shows up in the emergency room and gets a CT scan immediately? Well, we have chest radiologists. They're really smart, and we can talk to them, and we can say, hey, you look at this CT. Does this look kind of more like pulmonary edema? Does this look like tree and bud infiltrates that you'd expect more as an atypical infection? Or does this look like COVID-19? And the chest radiologists, they're trying to look at that. I know that they actually were able to review the 1,000 CTs that were done in Wuhan, and they've been looking at it and trying to come up with ways for us as clinicians, if we have the CT. So if we have it, great. But if we don't have it, I don't think we need to order it. I've gone on for 30 minutes. This has been a soliloquy. What else? I'm looking at Dr. Vaughn and Dr. Monday, trying to get a little guidance if I need to go with anywhere else.
What do we do if our patient on the floor tells us they have flu-like symptoms?
Ah, yes, that's a common question. That's right, we're getting a common question, and we've all called each other with the common question. What do you do when you're rounding on your non-COVID-19 patient And then the non-COVID-19 patient tells you, I have flu-like symptoms. They could have flu-like symptoms because they've got Pseudomonas bacteremia. They could have flu-like symptoms because they have the flu. Take a step back, be clinical, look at the patient. Lymphopenia really is important. And if they don't have lymphopenia, that already helps. If they don't have fever, that helps. And so clinically, I think all of us are going to be faced with this. Well, wait a minute, what's my pretest probability? What is my overall assessment for the risk? Yes, I'm thinking that there's going to be a generalized sort of uptake of this virus based on all of the reports of asymptomatic patients. But when I'm a clinician in the hospital, I got to be clinical. So if I'm rounding on a gunshot wound to the leg and they're saying they got flu-like symptoms, and I'm going to see the CBC and they got normal lymphocyte count, that helps. Other questions?
Surgery team, what precautions should we do if we have to deal with intubating this patient or dealing with them in a trauma bay?
So another question is what if there is a patient that is an extremist that needs to be intubated in the trauma bay? Cover your face as quickly as possible, and cover your eyes. Eye shield and N95. There is a concern that we may not have enough, but anything is better than nothing as we're trying to figure this out moving forward. In the best case scenario, then the person should have PPE. Oh, I'm seeing questions popping up on the chat. Okay, that's cool. Oh, yeah, that helps. Yeah. When do they prone? You're asking me that question.
The Iranians are even doing self-proning on nasal cannula oxygen and having people flip themselves.
Dr. Monday said that she's already hearing reports that even on supplemental oxygen, prone may be helpful. I don't know if I can really provide you when to prone. I can tell you that in the Italian experience in Milan and in Bergamo, which is basically like Plano, they have been proning everybody after they intubate them. And so maybe as a group of intensivists, recognizing that this will evolve rapidly, we may end up seeing that as well. Like maybe standard of care, if somebody has COVID-19, it's the moment they have it, prone them, and then figure it out later. And so that's kind of one thing I'm thinking about. Oh, cardiac issues. Good question. So the Chinese experience had actually described a not small number of cardiac issues, between 5 and 15% of patients developing viral myocarditis, pericarditis, also with heart failure. This is something we've seen with influenza. We've also seen it with parainfluenza and other respiratory viruses. The Italians are not reporting a sort of cardiac issue. So I don't know where we are with this. Some of the critical data suggests that checking a troponin may be helpful. But then the flip side is, why should you check it if you're not going to call cardiology to do a cardiac cath because you're not really acting on that troponin? There also are greater reports of arrhythmias. And so we may have to have liberal supportive measures for atrial fibrillation, SVT, etc. So I'm seeing the chats. This is helpful. Okay, so there's questions about proning, rotaprone. These are good questions. I can't go there. We're not there yet. We're going to have to think about that stuff, and that'll be probably some other discussion later. Other questions you guys can pop up there. That's kind of cool. That just pops up.
What are we going to do with the bodies?
The question is what are we going to do with the bodies? That'll be an interesting question. There was an article in the Washington Post this morning about what's going on in Bergamo, and the hospital morgue is full, and all the mortuaries ovens are running 24/7. I don't know if that's going to happen in Dallas. I don't know where we are on the curve. We may have flattened the curve. we'll have to see with that. And we also, once again, have to remember that, yes, we're hearing about how some state is saying something, but let's be all part of the team and let's not shout at each other if we're saying, oh, we need to, cremate all these bodies. Like, we don't know yet. We don't even know if that's necessary because this isn't Ebola. So I'm not sure what's going to happen with funerary practices. Let's see. Will it be proning patients in beds without rotoprones? That's actually what they were doing in Milan. And so that's a discussion for you guys for the ICU of how hard is that to do.
Handout and training to come soon.
There you go. And so Dr. Monday said handout and training to come soon. All right. All right. Yes, the protocol will be manual proning and how to do it. Hey, these are great questions. Like, that's the kind of way we need to start thinking. We start clinical. Like, what are we going to do? Okay, we got to prone them. Got this. How are we going to do it? All right. Other questions? You can type away. It kind of works really nice with the chat thing. Any other questions about antivirals, interventions, vaccine? They're saying there's going to be some vaccine data, but, it took Ebola. They actually were able to come out with an Ebola vaccine in about 4 months, and we're able to do a rapid trial. They are talking about a vaccine trial in Seattle already, recognizing that the actual disease is prevalent within the greater Seattle area. They are screening individuals who are asymptomatic and they're checking their serologies. Questions about sort of management. Good question about daily chest x-rays. I don't think so. In fact, we may not be using our stethoscopes because it may be too hard to clean them. And so we may just be acting on pulse oximetry and overall clinical status. This respiratory failure does seem to be different than other respiratory failures. When I think of sort of the more severe respiratory failure of the 1990s, pneumocystis, I'm not seeing reports of pneumothoraces. I'm not seeing reports of significant barotrauma. So getting daily chest x-rays is probably not necessary. And in fact, in some of these patients, daily physical exams. Another question. So what about the anti-malarial? Wow, you infectious disease doctors want to treat a viral pneumonia from China with an anti-malarial. Well, wouldn't you know that Plaquenil or hydroxychloroquine actually has weak activity against the ACE2 inhibitor, the ACE2 receptor, so that it may reduce the uptake of the virus at the cellular level. So there's already a buzz in the last 36 hours. This may be more useful for prophylaxis than for treatment. When we treat viral diseases, remember that time is when you need to treat them early. So if they're already in the cytokine storm, already with complete respiratory failure, then whatever we do probably isn't going to help, which is similar to Tamiflu in the sickest patients. And so the hydroxychloroquine is a good thought. Unfortunately, there's already a shortage. And so I think we're going to have to figure out how to use the drug because I don't know if we can use it universally. It does have technically some potential side effects. You need to pay attention to the QTc interval and also the liver function tests. Next question is ACE inhibitors and the association with the disease. Wow, this is confusing. About a week ago, there was a thought that they saw that in China, the signal was that if you had hypertension, male, over the age of 50, and you acquired this infection, your mortality risk was over 50%. But they still haven't teased out why. They haven't teased out what the comorbid conditions are for that 50%. So are these patients dying because of their hypertension or because of their hypertension therapy or because of some other reason? Don't know. And so people are saying, well, does that mean I'm putting them on an ACE inhibitor and then I'm preventing the uptake of the virus? Or if I put somebody on an ACE inhibitor and they've been on an ACE inhibitor for chronic therapy for their essential hypertension, do they have an or an increase of cellular receptors because of that inhibition. And so are those the patients who are getting sick? So we have these very confusing signals. So we don't know. So clearly wouldn't use ACE inhibitors as a treatment modality, would pay attention whether or not your patient, if they presented, was on an ACE inhibitor, but also can't really recommend saying, hey, my best friend, he's on captopril. Am I supposed to tell him, stop your captopril tomorrow because it's going to save your life? No, can't say that at all. As far as angiotensin receptor blockers, tongue-tied, or ARBs, same sort of question. Don't know if there's a difference in one signal or the other, but there already is some research being done on this. I just saw some data even last night that suggested that ARBs were protective. So who knows? Maybe we'll see one signal or the other for one or the other. So another question is are we reaching a point where we have a database of these patients for research? Not to my knowledge. This is a very good question, and yes, mega data will definitely help us as we move forward. There are some single center outreach to try and gather the data. I know that they're also looking at gathering the data in the University of Washington as well as in the San Francisco area. I don't know what's going on in New York yet, but I imagine they're doing the same thing. I like the questions. It's nice.
Steroids, vitamin C.
Oh, Dr. Monday asked steroids and vitamin C. So steroids probably hurt. Vitamin C, don't know. And so some are advocating the use of vitamin C, and I think the signal for vitamin C is still going to be somewhat controversial. There are questions about liver function tests. Yes, it does appear that many of the patients have mildly elevated liver function tests. It is not clear if this is a viral hepatitis or if this is some sort of parahepatic phenomenon. I do not know of any studies that show liver biopsies on these patients, for example. Within the clinical trial, the exclusion is if their liver function tests are 5 times above the normal limit. And so it does seem to be associated with a worse outcome if they have evidence of frank hepatitis. Other questions. Kids. Kids are fascinating. They keep looking at the data. The data show that kids do not get critically ill from this illness for reasons that are not understood. They are not reporting critical illness in neonates, preemies, children, toddlers, teenagers, none of them. However, they are making a lot of virus. And so there have been some studies that had been done in Western Europe already, in the Netherlands, where they show that asymptomatic passage of virus from children does happen. So we need to report or remind everybody that, remember, it takes a village. The children can transmit it to the older people. And we do know that the older people are susceptible. Next question is about pregnancy or breastfeeding, increased risk or mortality. Very little data to suggest this at this time. Not really seeing much yet. Do not know if this is an underreporting or if this is truly clinically relevant. We obviously are always worried about pregnancy and are trying to help pregnant patients avoid this at all costs. Next is mortality with kids. Data from China with 11% severe disease in that group versus 6% in kids overall. Right, and so that's the China data. And then the Italian data that's finally being put out over the last week is showing really no disease in kids. And so there's something about the pathophysiology. I don't know what it is with kids. I don't know if it's because they have a different number of receptors with this virus. So stay tuned. Other questions? All right, looks like we're questioned out. So Dr. Vaughn, Dr. Monday, we're good?
Great, thank you.
Okay, guys, thank you for your attention. Thank you for getting together. Remember that we're all in this together. And yes, there's a question at the end, neutrophil lymphocyte ratio, and that'll be in my conclusion. That's a great way to make concluding remarks. So in conclusion, new virus, we're learning a lot. We actually have data to assist in the diagnosis of this disease and the management of severe illness. Look at the patient's blood, specifically their CBC. Look at the neutrophil count, absolute neutrophil count. look at the lymphocyte count, the absolute lymphocyte count. Take the ratio. If the ratio is greater than 3.5, these are the ones that are most critically ill. If the patients have a normal lymphocyte count, an absolute lymphocyte count that is within normal limits, odds are they don't have this infection. This is not a hard and fast rule, and we may learn more, but this is a great way for us to assess because, as you guys know, everybody gets a CBC in the hospital. So a CBC with diff is fine. You don't need to trend it. You don't need to get a daily CBC. You don't need to follow the lymph count or the neutrophil count to see what's going on. And so that's kind of the most important take-home message, I think, if you look at that. And if the ratio is greater than 3.5, they say that those are the ones that really proceed to respiratory failure quickly, so they need to be monitored closely. So I thank everybody for your attention, and good luck to everybody. And I even see some joking texts. So yes, humor will help, and memes will help. Everything will help. And remember, we're all in this together. So good luck to everybody, and I'm sure I'll be talking to you guys throughout the weeks that come. And I'm signing out.